Good afternoon, everyone. My sincere thanks to Dr. Sharma, Dr. Mehran, Dr. Kinney for providing me the opportunity to present moving ahead. So my case is a successful bailout edge-to-edge repair. So yeah. My patient was a 71-year-old gentleman who presented with us with a worsening class 3 heart failure symptoms, and he had multiple admissions due to heart failure exacerbations. In his past medical history, he was hypertensive, his coronaries were non-obstructive, he has Parkinson's, dementia, and past history of CA prostate, and he was very frail. His BMI was 19. He was on appropriate medications, his labs were unremarkable. Uh, because of his frailty and on his echo, there was a severe MR due to flail P2, P3 scallop, and it was a primary MR with a possible etiology of the Barlow's valve with alongside moderate microannular calcification, and there was mild to moderate TR. The EF was preserved to 60%. So this is a transesophageal echo which shows the severe MR and the leaflet, posterior leaflet is flail with the anteriorly directed jet. This is the bicommissural view which shows us the flail P2 scallop, and there is a prolapse at the A2 scallop as well. And this is a three-dimensional view which shows that there is a flail P2 scallop and that leads to severe MR. So after heart team discussion, because of his severe frailty, his BMI was 19, his multiple neurological problems, after discussion with team's heart failure surgeon as well as neurologist, it was decided to proceed with the TR, that is microclip therapy. So this is the mean gradient. The pre-mean gradient was 1, and we can appreciate that the leaflets, because of the flail pathology, the leaflets were pretty long. The posterior leaflet was 2.6 and anterior leaflet was 1.76. So we took the transeptal with a safe cross system, and we can appreciate on 4-chamber view that the height was appropriate. It was 4.5 centimeter. And our initial plan was to go from the medial to the lateral, from P3 to P2, but however, because of the flail pathology and too difficult to grasp the leaflets, we went at the A2 P2 scallop first. And we can see that our clip was appropriately oriented at the A2 P2 level on 3-dimensional TE. So moving ahead, so our clip was appropriately oriented, and the first clip we chose was XKW because of the long leaflet length and the wide flail segment. So following the appropriate leaflet grasp, we can see that there was no parallax, and following the appropriate grasp, there was a significant reduction in the mitral regurgitation. And we can appreciate that the PLA pressures from the mean of 14 dropped to 10 with a V wave drop from 32 to 18. We can appreciate on 3 dimensions that there was a stable clip with good tissue bridge, and there was a residual jet medial to the clip with the mean gradient post-clipping was 2. So because of the regurgitant jet and the posterior leaflet prolapse medial to the clip, we can see that there is a regurgitant jet medially. We went with the second clip, and because of the commissural, jet, however, the long leaflet, we decided to move with the XT clip. The leaflet length over here is important to emphasize that the posterior leaflet length was 2.3 and anterior leaflet length was 1.7. So we took the second clip. We can see the orientation of the second clip medial to the first clip, and we went with the simultaneous leaflet grasping, which can be very well appreciated over here. Following the appropriate grasping, we can appreciate that there was a significant reduction in the MR, and the mean gradient remained at 2. Before releasing, we went for, we assessed the leaflet length, and the residual leaflet length was 1.3 posteriorly, and anteriorly it was 0.6. So this means that we have grasped around 10 mm of the posterior leaflet and 11 mm of the anterior leaflet. And 3 dimensions show that there is a stable second clip, and there is a significant reduction in the MR. There is mild MR, which is lateral to the P2 scallop. And the LA pressures came further down, and the echo shows there is a remnant mild MR because it's a degenerative valve, so there is a mild MR lateral to the P2 scallop. So we went with the third clip with the same technique lateral to the first clip, and this was again XT clip. And following the grasping, we can see that there was a minimal MR and the mean gradient remained at 2. And we can appreciate that there is a good tissue bridge, and now we can appreciate the severe MR came to minimal regurgitant jet. We can appreciate the pulmonary vein flow reverse from initially there was a systolic reversal, and then there was a normalization of the flow. On fluoroscopy, we can see that all the 3 clips are stable, and all the 3 clips are appropriately oriented, and the final LA pressure was mean of 8 with a V wave of 12. However, subsequently on post-procedure echo, there was a regurgitation of the severe MR and there was a hypermobile mass seen in the LA. And we can appreciate that there is a hypermobile mass, so the possible etiology of the recurrence of the MR was the single leaflet device attachment, that is, our device has detached from the one of the leaflet. So this was confirmed on transesophageal echo, where we can see that the medial clip, which was an A3P3 scallop, this is hypermobile and this has detached and this has led to the recurrence of the MR. And the pulmonary vein flow pattern, which was normalized, has again reversed. So we can appreciate the reversal of the flow pattern. And on three-dimensional view, we can clearly appreciate that our clip at the A3P3 scallop was detached from the anterior leaflet and it was the cause of the severe MR. Good. Yeah, so there was a recurrence of severe MR. Next slide. And this is the fluoroscopy view where we can see the dancing clip, the medial mic of the clip at the A3P3 scallop. So because of the high risk patient, initially we decided, decision was that to go for a redo tear procedure where the thought process was to clip it between the first clip at A2P2 scallop and the SLDA clip. And we assessed the leaflets were appropriate. There was 1.34 anterior and posterior was 0.9. Next slide, please.
Okay. Just leave it.
Okay. So we went with the careful. I was trying to show that because there was a SLDA clip. So for the redo procedure, clip procedure, we were trying to carefully steer the new clip, and we were checking the grippers higher up in the LA so that to avoid the interaction of the grippers with the SLDA clip. And we tried to align the clip between the SLDA clip and the clip at the A2P2 scallop. This is the slide which I was trying to show that they were to do the careful steering in the LA and checking the grippers high up to avoid the interaction between the SLDA and the grippers. Just moving back. So here we can see that inner alignment of the redo clip, we can see that our SLDA clip is abutting the new clip, and this is not working. However, and this led to the movement of the SLDA clip towards the ventricular side, which led to a short episode of the NSVT. We withheld the procedure, we came back to we brought the clip back to the LA, and after reorientation, we went back into the LV. Following this, we tried multiple episodes of the multiple times of simultaneous leaflet grasping. How we were able to grasp the anterior leaflet, but because of the interaction with the posterior leaflet with the SLDA clip, we were not able to appreciate the posterior grasping. Here we can see that there is a good anterior leaflet bounce is there, but we cannot appreciate posterior bounce because the SLDA clip is interacting with it. So we reoriented the clip and we thought to proceed with independent leaflet grasping. We closed clip from the 120 to the 110. Further, we closed the clip and we went with the anterior leaflet grasping. The thought process behind the closing was that it would lead to lesser interaction with the SLDA clip. And we went with the independent anterior and then independent posterior leaflet grasping, and following which, after confirmation, we went with the closure of the clip. And we can see that there was adequate leaflet grasp and the MR was MR reduced from severe to mild. We confirmed it, the stability of clip in various transgastric views as well as three-dimensional views, which shows that the clip was stable and there was mild regurgitation left. LA pressures which rose from 20 of mean, it came back to the were normalized, and the pulmonary vein flow pattern was again normalized. And echo shows the stable clip and the fluoroscope is not working. And this is the final post-procedure echo, which shows all the clips have been stable and the MR was mild and there was a mean gradient was 2. So summary was that the patient was a very frail patient with a class 3 symptoms who was treated with a microclip procedure with 1 XTW and 2 XT clip. Here recurrence of the MR because of one of the complication that is SLTA of the clip at the A3P3 scallop, and which was successfully managed with a redo tear with one XT1 clip. So this is my last slide from the to summarize the causes for the SLTA, which can be because of inadequate leaflet capture. However, in our case, the leaflet capture was more 11 mm anteriorly. Other possible etiology can be poor tissue quality, which can be one of the reason in our case, because our leaflets were degenerative Barlow's valve. In these degenerative leaflets, that can give away from the clip. The third possible reason can be excessive clip leaflet tension. However, we went with the simultaneous grasping, so possibility of excessive clip tension was not there. With this, I would like to end my presentation, and I would like to thank the organizers, and I'm open for any questions over here.
Clearly, you worry about the embolizing the clip.
Yeah, that was one of the concerns. So
Thing. But I think this is the way end results are. It's to 4 clips in this particular case and really helped it. I think you should make it a case report on the jack imaging, and so they take those kind of cases with the video loops and so. And so.
I couldn't grade this person.
All right.
So let's
Good. Okay, we are just deciding and we are going to call back.